Good morning, good afternoon, or good evening, wherever you are listening from. Welcome to the official Pasid 2025 Voices podcast. I'm Professor Hussam Araf Ghazi, Pasid President, and I'm a Professor of Medicine and Interventional Thyroidologist. Today, it is my great honor to do this podcast with a pioneer in the field of thermal ablation and thyroid interventions, Professor Lin Wei Chi from Taiwan. He is internationally recognized expertise in the field of thyroid interventions, and he is especially have a lot of publications and a lot of lectures about the role of thyroid thermal ablation in the management of thyroid cancer, especially as this is a minimally invasive procedure used and make a groundbreaking role in treatment of such condition. Professor Lin, welcome to Egypt, number one, and welcome to Pasid, number two, and welcome to our podcast, number three.
Welcome everyone. Thank you for the invitation of Dr. Hassan. I'm very happy to be here.
Thank you, sir. Welcome to Egypt. Professor Lin, let's start and begin with the basics for our listeners, because not all of them are specialized in the field of thyroid interventions, and not of them have a lot of deep knowledge about the thyroid cancer. Thyroid cancer is worldwide is increasing, and the prevalence of the thyroid cancer is increasing. Could you help us? Why is this happening? Because this is a lot of concern about the patients. A lot of patients say to us that the prevalence of thyroid cancers are increased. From your experience, could you elaborate why the prevalence of thyroid cancers is increased?
Okay, thanks for this wonderful question. I think that for the past few years, because modernization changes globally, so I think a lot of new pollution come into our life, especially for thyroid. Thyroid is a hormone organ, so you can see how important that it can balance with all other organs. But now we have used a lot of plastic material and a lot of makeup, especially for the women. So all of this may make a little bit increase of the risk of the thyroid cancer. And I think another reason that quite tricky is that usually we will get benefit from the advance of the new tech, especially the image modality. But for the past 10 and 20 years, more and more thyroid have been surveyed, especially during the health examination by all kinds of modalities such as ultrasound, CT, and MRI. So that's a lot of incidental findings of the thyroid cancer. Most of them are small and will not be found in our daily exercise unless it becomes very big or cause some voice changes that will be found. So I think recently the dramatic increase of the risk and the diagnosis of thyroid cancer may be part of contribute to the increased examination of the thyroid. Sometimes we call it overdiagnosis.
Yes. Okay, regarding thyroid cancer, the gold standard treatment is the surgery. And traditionally, until now, surgery is the gold standard for the treatment of thyroid cancer. Especially before cancer, even those with a suspicious nodule in the ultrasound, with a suspicious FNA, surgery is the main line of treatment till now. Can you summarize to us and our listeners what is the advantage or the strength point for the surgery, total thyroidectomy, regarding such cases, and what is the disadvantage of surgery regarding these points, especially if the patient is having the total thyroidectomy or lobectomy and the results just was follicular adenoma or just Hashimoto thyroiditis, for example? What is the advantage and the strength point of surgery regarding suspicious nodule, and what is the limitations?
Okay, I think the first advantage of the surgical resection is that we can have a complete confirmation of the pathology of the lesion, no matter it's initially been diagnosis of the cancer or it's just indeterminate. So I think once patient know that she got or he got a cancer in the thyroid, I think that was very difficult to get a sleep, and they were worried about the condition of the cancer within the body.
Yes.
So I think, but luckily, most of the thyroid cancer actually is quite good, especially most of them are papillary thyroid cancer. So I think the one issue is that if the patient really worry about the cancer in the body, thyroidectomy or surgical resection definitely is the best way to solve this problem.
Yes.
And the second one is that when we go into the neck with surgical resection, at the same time we can not just only take the thyroid out, but we also can explore the neck and to find out is there any lymph node metastasis or the lymph node was infected by the malignant cancer.
Yes.
So that can help us to have a well schedulation of the following treatments such as radioiodine therapy or the follow-up interval for our patient. So I think that's the best way to that because sometimes we will find initially in the fine needle aspiration is benign, but after surgical resection it turns out into malignancy.
Yes.
And also we need to agree with that. Ultrasound is highly operator dependent. So I think maybe not all of the ultrasound study is well studied, and sometimes some small lesion was not founded. So I think the best benefit is that we can have a global view of the condition of the thyroid. But of course, we need to say that some patients really is scared of the operation, including the general anesthesia or the voice changes, the complication carried out by the thyroidectomy. So I think from this point of view, minimal invasive procedure or partial thyroidectomy might have some benefit to our patient.
Great answer, sir.
Yeah.
So let's talk now about the innovations. A lot of doctors and patients actually heard about the thermal ablation like radiofrequency and microwave. Could you simply tell us and tell the listeners how this innovations in the field of thermal ablation work in destroying or treating thyroid nodules, either benign or malignant one?
Okay, that's a very good question because I promote the thermal ablation for more than 10 years. And I think it's a quite convinced method so far for not just only for the patient, but also for a clinical doctor. And previously, the disease was treated by the surgeon, and also the endocrinologist also worried about the cancer was not found, so they prefer refer them to the surgical resection. But now, once we introduce the minimal intervention of the thyroid, especially for the benign or cancer, the first one is the radiofrequency ablation. Just like the energy you listen, but it's delivered in different way. The radiofrequency ablation is after the local anesthesia with the skin and the thyroid. You can advance the needle into the thyroid, no matter it's benign or malignant cancer. Then you turn on the power, then the temperature would increase. You know that most of the body was made up by the protein. So once the temperature is more than 40 or 45, something like that, and everything will be destroyed. So by using this concept, the thermal ablation with a very tiny needle advanced into the tumor, they can kill the lesion in second or minute. So it brings a lot of benefit to our patient without surgical resection or stay 1 day or 2 days in the hospital. And the recovery is actually very fast. A patient will not experience very severe painful sensation or any consequence after the thermal operation.
A lot of our listeners and doctors may be curious about the use of the radiofrequency or microwave in management of cancer. Maybe a lot of doctors, especially surgeons, maybe it is not the interest for them if you are doing ablation for the benign, because it is a benign problem. But regarding the malignant problems, there is a lot of doctors are angry about this and worried about this. From your experience, Professor Lin, what is the best selection criteria to use thermal ablation to ablate the thyroid cancers? And how strong the evidence about it? What's the guidelines? I know that you are one of the authors of a lot of guidelines regarding this and consensus. From your experience, what is the best selection criteria for such cases?
Okay, I think when we back to the treatment of the cancer, of course, we really appreciate so many years the work that has been done by our surgeon. They do a lot of treatment, especially in the treatment of thyroid cancer.
Yes.
But anyway, some of the patients did not really can tolerance to all the procedure because of old age, comorbidity, diabetes, heart disease. Anyway, that made the surgical resection obviously increase the risk. And since the thyroid cancer is a relatively benign cancer, so the lifelong or like expected treatment survival can more than 10 years. So it gives us thinking that whether or not we should really carry a high risk to our patient that they cannot tolerate well to the surgical resection. So I think first one, if the patient cannot really tolerance of the surgical resection, it would be a good candidate because anyway, we treat the cancer. The second one is the location of the cancer.
Yes.
Now did not have very strong evidence how big of the cancer can be treated or cured by thermal operation. But so far, the small cancer, for example, lesser than 1 centimeter or even lesser than 2 centimeter, if the location of the tumor is very well, it means it's far away from the dangerous critical structure, such as the nerve or trachea or the vessel, I think that would be a good candidate to accept the thermal operation. But so far, I would not say that we really using thermal operation to cure the thyroid cancer. But at least it is an alternative method compared to the surgical resection because it's a really more minimal invasive and lesser complication compared to surgical resection. So if patient accepts thermal operation, we highly recommend the patient continue to regularly follow up in the hospital, maybe every 6 months or 12 months, something like that, to identify any incomplete abrasion of the lesion or undetected lymph node of the neck. Then you can shift the treatment into the surgical resection. And from the guideline we just made and just published this week, theoretically, we all thinking about this rule. Maybe not, still not the right time to generate to all over the world because there are some problems still need to be solved, such as that how to identify the lymph node metastasis because based on the surgical experience, 10 to 30% of lymph node can be found. Even the cancer risk is very low. So I need to say that we are in the right way. And since the risk of the thyroid cancers is not so severe, so I think it gives us a window that we introduce the thermal operation to help those people that cannot really get benefit from the surgical resection.
Yes. Okay, this is the present and looking for the future. From your experience in the next 5 to 10 years, do you think that there will be a change in the role of radiofrequency or thermal ablation in the management of thyroid oncology in general? Do you think it will be changed, especially with the growing evidence and growing studies about this?
Yeah, that's a very good question because so far for most of the cancer, surgical resection is the first choice. And of course, after surgical resection, we have radiation therapy. Then the patient keeps active surveillance. But for thyroid cancer, it's quite often to get regrowth. So patient may suffer from repeated surgical resection or radiation therapy, repeat again. But anyway, these two management will fail someday. And for the rescue method is the tachytherapy, external radiation, something like that. But anyway, both of them have first one is accumulation doses.
Yes.
The other one is the high doses of tachytherapy sometimes may carry a lot of problems such as impair the renal function. But when we're talking about a thermal ablation, actually it's a method that you can continue to repeat it. It means that you can treat no matter when you want to do it again.
Yes.
So if we not mention about the primary cancer, we just focus the majority for the recurrent cancer. I think thermal ablation bring the new, milestone in the management of the thyroid cancer because sometimes the thyroid cancer cannot be resection anymore. It did not have any benefit from the radio iodine therapy. But now we have IFA, we have thermal ablation. When we introduce the thermal ablation in the management of cancer, it becomes more combination therapy can happen. And sometimes we can use a partial treatment of thermal ablation and combine with external radiation or thermal ablation combined with tachytherapy. It can enhance the traditional therapy effect that we think is not so good in the radiation of the target therapy. With the help of a thermal ablation, the cancer may become cured. It's possible in the future. So
Yes.
I really encourage all the hospital, no matter the endocrinology, radiology, surgeon, try to get involved in this field of thermal ablation because I really saw it happening and bring a lot of benefit to our patient.
Yes, and this is I would like to highlight about this last question to our podcast. What's your advice from an expert, one in the field like you, for the young generation who would like to join us, whatever their specialty, either endocrinologist, radiologist, nuclear medicine, surgeon, whatever their specialties? What is your advice from a long experience from you to be efficient in this field? Can you give us simple, scheduled advice for them?
Okay. I think the first one is try to open your mind because I think the thermal ablation introduced into the thyroid is a very obvious changes compared to the previous decade because since 100 years ago, thyroidectomy is the only therapy to the thyroid cancer. But so many years later, it's still. So when we're talking about a thermal ablation in the treatment of thyroid cancer, it's a brand new concept in the treatment of thyroid. And when we're talking about this method, we can look back to the treatment of the liver cancer. So far, if the cancer less than 3 centimeters in liver, the thermal ablation can be the first line to treat the malignant cancer. And we all know that for the liver cancer, the malignancy potential is even higher than the thyroid cancer.
Yes.
So I think definitely the method would introduce into the management of thyroid cancer play some kind of role. Maybe not a majority, but it would be definitely.
Yes.
But when we facing treatment of benign or malignant cancer, it's totally different concept. For benign lesion, we just try to reduce the symptomatic effect due to the huge mass. We can incomplete treatment of the benign lesion, but it's not the same when we're treating the thyroid cancer. So, but anyway, you need to learn this skill. So try first from the benign lesion and try your best. Try to ablate all of them, then you can feel very comfortable when you're facing the cancer condition. You can do very good water dissection to separate the tumor from the critical structure. Then you have the way to complete ablation the lesion. And the second one is try to cooperate all the subspecialty in the field. I would call this a multiple discipline management of the thyroid cancer. Because for the small cancer, low risk cancer, sure, we can see it's quite convinced using thermal ablation. But for large cancer, for recurrent cancer, thermal ablation is just one of them. But with other methodology going to this game, I think the cure for the thyroid cancer and the prognosis rate of the thyroid cancer will become better and better. So I really encourage everyone to jump into this game, to discussion more, and we will bring a lot of benefit to our population.
Just one question now jumped into my brain. She's not prepared actually to be in the podcast. A lot of challenges that faced me in Egypt and a lot of my colleagues in the Arab countries, that thermal ablation is not covered by the health insurance. This is the main problem, the main challenges for us. Can I know how is this situation in Taiwan, and if it is not covered previously, how did you convince the policymaker to make it covered and to be not paid by the patient? This is the main problem actually in Egypt and Arab countries.
I think actually healthy insurance is not just a healthy issue, but it's also a political issue in different countries. In Taiwan, the same. We separate into the benign lesion and malignant lesion. For the benign lesion, sure, it's not necessary to treat the benign lesion. So I think it's reasonable patient pay by themselves if they really want this minimal invasive approach to treat their thyroid nodule. But for the cancer, I personally strongly recommend, and I will also try my best in that direction to push my ball, and also the government try to make thermal operation thyroid cancer be covered by the government health insurance. As I know, in Korea now the benign region will patient need to take care of that, but the thyroid cancer are already included into the health insurance of their government. So I don't know what's the situation in Egypt or other area.
Not covered, either benign or malignant. Not
yeah,
covered.
so I think that's what would be a good news because anyway, we say the thyroid is a good advantage compared to thyroidectomy. So if one day we really can manage well to the thyroid cancer, I think it should be covered in the future.
Professor Lin, thank you very much for this inspiring insights. And now it is clear that the minimally invasive procedures like radiofrequency, microwave, or any part of the thermal ablation is not just the future. It is the current, present situation now. To our listeners, stay tuned for another new podcast with another one of the distinguished international guests to Pasid 2025. I'm Hussam Araf Ghazi, the Pasid president, and stay tuned for the next podcast. Thank you.
Thank you.